Thanks to the organizers for inviting me to speak at the Asia-Pacific HIV Clinical Forum on constructing an effective HIV regimen after treatment failure. Here are my disclosures. So I'm going to cover the current WHO guidelines, what to switch to, and I'll take it from the perspective of without resistance testing, which is typical of the practice in many situations. So what to switch to if you fail on a first-line non-nucleoside-based regimen, what to switch to if you fail on a first-line dolutegravir-based regimen, and then at the end, I'll cover what's the added value of resistance testing. So first of all, if we look back at the WHO guidelines from the very beginning of the rollout program in 2003, they've recommended after failure on a non-nucleoside-based regimen, a favirenz-based regimen, to switch to a PI-based regimen, usually lopinavir, atazanavir, or darunavir. And at the same time, also, they've recommended since the very beginning to switch the nucleosides when you switch the other drugs. So switch from zidovudine to tenofovir, or vice versa. If you start on tenofovir, switch to zidovudine. So that's been the standard recommendation for the longest time about how to treat failing patients. But in July 2021, the WHO issued some new guidelines, and in that they recommended for the first time to replace the protease inhibitor in second-line therapy with dolutegravir. So if you fail on a non-nucleoside-based regimen, to switch to dolutegravir plus new nucleosides as the preferred second-line regimen. Even in these guidelines, they still recommended using an optimized nucleoside backbone, using this switch. So for patients on tenofovir 3TC, which is the commonest nucleoside backbone in first-line therapy, to switch to zidovudine 3TC in the second-line regimen. And that's summarized in this table here. So failure on a favirenz-based regimen, switch to dolutegravir, switch to tenofovir to zidovudine, maintain 3TC. And as an alternative second-line regimen, then you've still got the protease inhibitors, atazanavir preferred, lopinavir and darunavir somewhat in the background, and again with a switch to zidovudine 3TC. So that's the current guidelines as of July 2021. And what I'm going to do in this talk is walk through the evidence for that and some new evidence which partly supports and partly challenges those guideline recommendations. So first of all, let's look at the evidence for efficacy of switching to 2 nucleosides and protease inhibitor in second-line therapy. And I'm going to talk about the EARNEST trial here. So this is what to do when you fail on a nucleoside, non-nucleoside-based regimen. So in the EARNEST trial, we randomized over 1,200 patients who were failing on a favirenz-based regimen by WHO clinical criteria or confirmed with a viral load test. We randomized them all to receive lopinavir as a protease inhibitor, but in the control arm, they received 2 to 3 nucleosides selected by the clinician, or raltegravir, or a PI monotherapy arm where they were induced with PI plus raltegravir, but then dropped the raltegravir after 12 weeks to continue PI monotherapy. The rationale behind that was we felt at that time these nucleosides and recycling nucleosides probably weren't doing very much in second-line therapy, and therefore we could just drop them and people would probably be do absolutely fine. So this was 144 weeks, so a 3-year study following the public health approach with monitoring. And critically, down the bottom here, the nucleosides were selected by the clinicians without resistance testing, as was the norm at the time. And here are the results just comparing the standard of care arms, so lopinavir, Kaletra plus 2 nucleosides in black versus Kaletra plus raltegravir in blue, the brand new 2-drug combination regimen, which everybody expected to do better than the protease inhibitor and recycled nucleosides. And you can see whichever threshold you look at, whether it's 400 copies, whether it's 50 copies, whether it's 1,000 copies, whatever your favorite, the protease inhibitor plus recycled nucleosides did just as well as protease inhibitor plus raltegravir. And that was a big surprise. Everybody expected that the raltegravir PI combination would do better. And so we needed to look a bit more about why the control regimen did so well. So what we did was we looked back at the nucleoside resistance on stored samples when patients entered the trial, and found that there was certainly substantial resistance. So 60% of people had intermediate or high level resistance to tenofovir, about 70% to zidovudine, and almost everyone had high level resistance to 3TC or FTC. So certainly lots of resistance. And then we looked at what people were actually prescribed in terms of nucleosides. and put those two things together and categorize people in terms of whether they were prescribed 0 active predicted active nucleosides, and that was the majority of people, nearly 60%, 1 predicted active nucleoside, so about a third, and very few people actually had 2 predicted fully active nucleosides, just 8%. So then we looked at the performance of that PI nucleoside combination according to the activity of the nucleosides predicted in the combination. And the nice thing about the EARNEST trial is we have 2 comparator arms. Firstly, the protease inhibitor monotherapy arm, which was stopped a bit early because it didn't perform so well overall, but it gives us a good benchmark for what are the nucleosides adding to the combination. And then we have the PI plus raltegravir arm as a sort of benchmark of optimally performing fully active drugs. And if we look first of all at the people with 0 predicted active nucleosides combined with the PI, you'd expect that they would sit very closely to the PI monotherapy arm, but in fact they actually did just as well, if not slightly better, than the PI and raltegravir arm. So again, that was surprising, telling us that something strange going on with these recycled nucleosides with resistance. With 1 predicted active nucleoside, it was almost the same. With 2 predicted active nucleosides, paradoxically, they did a bit worse. And at the time, we thought that was probably because they were coming into the trial with wild-type virus, probably not taking their medication regularly at all. And so these were people with poor adherence that were selected, and that was maintained throughout the trial. But in fact, it may actually be as much to do with the absence of the resistance mutations, which may actually be of benefit in some ways in helping the response. So very interesting findings about the interaction between a PI and nucleosides. And the conclusions from the EARNEST trial were that a PI and 2 nucleosides is a very effective combination. It's as good as a PI plus an integrase inhibitor, at least using the standard of care drugs at that time, which are lopinavir and raltegravir. And that nucleosides contribute substantially to the efficacy of second-line therapy. And that contribution is independent of nucleoside resistance and predicted activity from resistance testing. So it's a paradoxical relationship that we saw. So the next trial I'm going to talk about adds to this evidence base. It actually followed from the EARNEST trial, trying to dissect a bit further the contribution of the nucleosides. And in the NADIA trial, we looked at the evidence for the first time in a randomized way for the efficacy of this WHO recommended nucleoside algorithmic switch. And we also looked at the efficacy of dolutegravir as recommended by WHO, compared with a PI in second-line therapy, but with nucleosides with very low predicted activity or no predicted activity, which hadn't been tested up until that time. And it was done in a way relevant to the public health approach. So 2 questions addressed by the NADIA trial. Firstly, is dolutegravir non-inferior to a protease inhibitor in the public health approach in second line? And the second question is, can you maintain tenofovir? Is that non-inferior to switching to zidovudine in second line in the public health approach with either a protease inhibitor or a dolutegravir regimen and without resistance testing? So those are the questions we wanted to answer. Here was the trial design. So NADIA took people failing on tenofovir 3TC, non-nucleoside, in most cases efavirenz, and randomized them in a factorial way. So 2 separate randomizations, one to dolutegravir, the other one to darunavir, and we wanted to use the best in class protease inhibitor as the final chance to show that protease inhibitors were as good as dolutegravir. So darunavir in a once daily combination, 800-100, darunavir-ritonavir. And then once we'd randomized them to that, we randomized them to stay on tenofovir 3TC or to switch to zidovudine 3TC. And those who got zidovudine, if they had hepatitis B infection as well, we added in tenofovir, so they were on 3 nucleosides. Patients were followed up for 96 weeks, and at 96 weeks, the main outcome we assessed these regimens on was a viral load less than 400 copies. The primary outcome was at week 48. That's already, in fact, both have just been published. But at week 96, viral load less than 400 copies. So viral load monitoring was done open with the results going back to the clinician at week 24, 48, 96, following WHO recommended frequency. We also did a viral load at week 72, so about 18 months after switch, if they weren't stable at week 48. And obviously anybody had a viral load above 1,000 copies, we did a repeat 12 weeks later after adherence counseling. And resistance testing was done for confirmed viral load rebound, that was open, but we also did, similar to EARNEST, we did baseline blinded testing and also looked at viral load rebound above 400 copies at the end of the trial and centralized all that resistance testing. So on the face of it, it was a trial that was done in the public health approach using normal practices, frequency of viral load testing, sparse resistance testing, but obviously we looked in a lot more detail for research purposes afterwards. Non-inferiority trial, 12% non-inferiority margin. So recruited 464 participants. It was done in sub-Saharan Africa, but I think when you see the findings, it's clearly very generalizable to Asian populations as well. Half of the patients had a CD4 count below 200 at failure. About a third had a viral load above 100,000 copies at failure. 60% had tenofovir resistance. Almost everyone had 3TC resistance. Excellent retention in the trial, so just 3 withdrew and 8 participants died. 98% of visits attended, so very robust, clean data from which we can draw conclusions. So here's the first comparison, the dolutegravir versus darunavir comparison. And you can see here in the primary outcome, less than 400 copies suppression, 90% of the dolutegravir group, 87% of the darunavir group, essentially no different, tiny difference between them, less than 3%, and that wasn't, that overlap 0. So dolutegravir is non-inferior to darunavir, but not superior. And same findings at different viral load thresholds, sensitivity analyses, and so on. The interesting finding here was the resistance, though. In the dolutegravir group, there were 7 people who developed dolutegravir resistance during the trial versus none who developed darunavir resistance. And I'll come back to that later. In subgroup analyses, see, this was the main question coming into this trial, is if you give dolutegravir with nucleosides which have no predicted activity, will it do just as well as a PI? As I showed you with EARNEST, would it replicate that performance? And the answer was yes. So dolutegravir did just as well as darunavir when you've got no predicted active nucleosides. So that's a really important finding across multiple fronts. And looking at the other comparisons and subgroups, essentially there was no difference between dolutegravir and darunavir, all sitting very close to a 0 difference in multiple subgroups. So that conclusion was clear. The other conclusion, or the other comparison, tenofovir versus zidovudine, to stay on tenofovir 3TC versus switch to zidovudine 3TC, that showed a more marked difference between the groups. So here you've got tenofovir suppression, 92% less than 400 copies after 96 weeks, 85% in the zidovudine group. So that's a difference of 7%. That doesn't cross 0, and the p-value is less than 0.05. So that's telling us that tenofovir is actually superior to zidovudine after 96 weeks of follow-up in terms of viral load suppression. And that same finding, you can see similar, about 7%, 6-7% difference, was seen in multiple sensitivity analyses and at the different viral load thresholds. And when you look at rebound, 14% rebound in the zidovudine group, 6% rebound in the tenofovir group, again, statistically significant. So very clear that tenofovir is outperforming zidovudine after 96 weeks in this combination, either with a protease inhibitor or dolutegravir. And those resistance mutations were clustered a little bit more in the zidovudine group than the tenofovir group, although not much to choose between them, and I'll come back to that later. Again, subgroups for the tenofovir versus zidovudine comparison. The one way you'd expect zidovudine to win, have a clear win, is in the subgroup of people who come into the trial with a K65R, which is the signature mutation for tenofovir. But even in that group where you'd expect people on tenofovir to do badly, zidovudine didn't win. Actually, tenofovir is slightly better, nothing to choose between them. And again, if you look at the spread of the subgroups, so anything to the right of this line, the point estimate, tenofovir is better. So you can see in a number of subgroups, tenofovir is doing better than zidovudine, and in none of the subgroups was there a suggestion that zidovudine was doing better on this side of the line. So again, a fairly clear result. Let's look at the resistance mutations, those dolutegravir resistance mutations. Earlier on, I showed you the slide with 7 people with a viral load above 1,000 copies confirmed with dolutegravir resistance. When we look back at the end of the trial, we also find a couple of other people testing at thresholds above 400 copies of viral load rebound that also had dolutegravir resistance, so 9 in total. And what I've done, I clustered them here according to whether they were on zidovudine 3TC dolutegravir or whether they were on tenofovir 3TC dolutegravir. You can see that those 6 on zidovudine, 5 of them had high-level resistance to dolutegravir with this pattern here with a G118 or E138 pathway Q148. So high-level resistance, a very ominous cluster of resistance mutations. Just one had intermediate level resistance with a 263K mutation, whereas in the tenofovir, the 3 that had resistance there, all of them had an intermediate level and this 263 mutation, which is of uncertain significance. It may certainly be possible for you to control viral load replication, again, suppress viral load replication with that mutation. So when you look at it in the big picture, zidovudine is clearly worse on the resistance pattern with dolutegravir. Safety, there was nothing to choose between darunavir and dolutegravir, very little also to choose between tenofovir and zidovudine, just a suggestion of more grade 3, 4 adverse events in the zidovudine group, but really relatively well tolerated, not much to choose between them in terms of toxicity. So the conclusions for NADIA as far as dolutegravir and nucleosides are concerned are that you get durable suppression in second line with dolutegravir, even if the nucleosides have no predicted activity. And that supports the WHO recommendation to use dolutegravir in second line, but it also supports this programmatic switch of people who are on efavirenz, some of whom may be failing, some of whom not. Pretty much everyone can switch from efavirenz to dolutegravir, even without viral load testing and without resistance testing, where those are not available. So a very strong supportive result for dolutegravir 2 nucleosides, even though the nucleosides shouldn't be working. Dolutegravir resistance remains a concern. So I've shown you this pattern of mutation. It's still only a few percent, and we need to take steps to mitigate that. So certainly using tenofovir 3TC instead of zidovudine 3TC may decrease that risk of developing dolutegravir resistance, but also it may be wise to do enhanced viral load monitoring or adherence for at least for the initial 12 months in these kind of people who are switching where you know there's pre-existing nucleoside resistance, or you suspect there's pre-existing nucleoside resistance. And then darunavir nucleosides, equivalent efficacy without the risk of resistance. So that's clearly a potent combination. So if you need an alternative to dolutegravir in second line, then probably darunavir and 2 nucleosides is the one to go for. Tenofovir versus zidovudine, maintaining tenofovir is superior to switching, and that adds to the practical advantages of tenofovir in a fixed dose combination, tolerability, once a day, et cetera, et cetera. So the WHO's guidelines recommending this switch, which have been there for a long, long time, 15, 20 years, and now or should be reconsidered. So where does this leave us with sequencing and switching regimens? So this is the old plan where you had non-nucleoside-based regimen with 2 nucleosides. On failure, you'd switch to dolutegravir 2 nucleosides, and then for third line, you'd switch from dolutegravir 2 nucleosides to a PI and 2 nucleosides. But what we've got now, essentially with the non-nucleosides being sidelined or even switched or phased out, essentially we've got 2 very active regimens, dolutegravir or darunavir, each with tenofovir 3TC. And what NADIA has shown, and also building on the findings from EARNEST beforehand, is that actually it doesn't matter if you've got nucleoside resistance. You're still going to get a very good response with either dolutegravir or darunavir in second-line therapy. So you've got essentially 2 potentially fully interchangeable regimens. Obviously, you're going to start with dolutegravir, tenofovir 3TC because of tolerability and cost and fixed dose combination. But if the patient can't take that, or it fails on that, or for other reasons, then you've got a very good switch option, which is darunavir, tenofovir 3TC. So lastly, everything I've shown you so far is about treating patients without resistance testing. So let's now ask, what might the role of resistance testing be for drug selection when you switch from a failing non-nucleoside-based regimen, or even a failing dolutegravir-based regimen? So for selection of dolutegravir versus a PI, from NADIA, we know that both do well, both dolutegravir and darunavir in INSTI or PI naive, with or without resistance. So the programmatic choice is clear. The cost, fixed dose combinations, et cetera, favor dolutegravir, and there's no added value of doing resistance testing to suggest which nucleosides you should use. Just use tenofovir, continue tenofovir 3TC. The selection of the nucleosides in second line, well, I've just covered that. So from EARNEST and NADIA and other trials, we know that nucleoside resistance doesn't impair the response to a protease inhibitor or dolutegravir. And we know that from NADIA, tenofovir outperforms zidovudine irrespective of key signature mutations. So there's no added value of resistance testing for selecting nucleosides. So lastly, let me finish with some acknowledgements. This is the NADIA trial, but many of the people here were also involved in the EARNEST trial. So the Infectious Diseases Institute coordinated this trial from Sub-Saharan Africa. Here are all the site people, the site teams in Kenya, Zimbabwe, Uganda who did the trial, the IDI Coordinating Center, Janssen, who funded this trial, NADIA, and of course the trial participants in both EARNEST and NADIA who have contributed to these trials and led us to these very important findings for treatment. Thanks very much.